going to rely on Spanish internet connection. As it was mentioned by Dr. Sono, I managed to get on holiday for the first time for the last 1.5 years due to this pandemic. It's a great feeling, you will experience in some time, when this terrible time is over, how nice it's just to travel somewhere else.
You're waiting for that, sir.
Yeah, absolutely. Now, obviously, in those 15 minutes, you'll be able to see a few things you already saw at other meetings, but I promise I will also show you some new experiments we did, particularly in terms of hyperopia treatments using the SMILE procedure. And as you might know, for the last 5 to 6 years, we've been collaborating together with the group of Farhad Hafezi from Switzerland, who are well known in checking biomechanics in keratoconus corneas and other corneas. And actually, it turned out to be a very fruitful cooperation. We already published 5 papers and just submitted another one. Now, the background is quite known to every one of you, so I just make it short. I mean, you remember going back to 2013, then Reinstein and Randleman, they published a paper showing that basically SMILE procedure, after myopic SMILE, it's important now, the myopic SMILE procedure leaves the cornea stronger, with better biomechanics as compared to, let's say, FS-Lasik or PRK, and it was a purely theoretical work. On those days, we decided, okay, we want to prove it using experiments. And then again, I was looking for a group that knew how to check the biomechanics, because remember, when you do hysteresis, you do these core things, it's just a blow onto the cornea, but it's not what's happening when we experience keratectasia, because keratoconus and keratectasia, you have the forces from within the eye, not from the outside of the eye. And this is a device that's been developed by Hafezi group, particularly by Dr. Kling, who is part of his group, or used to be part of his group. This is their device, how they test the corneas. So we go to the human corneas. Initially, we did some porcine corneas, and then we moved to human corneas. And this is a paper that was published in 2018, where we had 22 fellow eye human corneas of 11 donors who were not suitable for transplantation. Obviously, we had to remove the epithelium because of those post-mortem corneas. Otherwise, the femtosecond laser does not work well. And we also checked the ultrasound pachymetry, which is quite important when you check the biomechanics. And basically here you see what we did. We did obviously a very large treatment, because remember, those corneas are very swollen. These are post-mortem corneas, and we use large zones. It was basically -10 diopters. For LASIK surgery, because there's no reepithelialization, I use fibrin glue basically to seal the flap as it would your epithelium of your normal patient would after a successful LASIK surgery. And that's what turned out, and that's what we published in 2018. It was a huge difference between the SMILE treated corneas and the LASIK treated corneas. Now, when you look at the stress-strain relationship, and you see this is LASIK and SMILE is way out superior, and it was highly statistically significant. Was no surprise to all of us, because this is what we thought, and it's just another type to show it. And basically, it gives you the idea that SMILE is 1.47 times stiffer than femtosecond LASIK for the same amount of treatment performed. So the next idea is, because you remember all of us, when we have those corneas that, wow, don't look very good, we say, why don't we just do PRK? Because it's safer than doing femto-LASIK. And the question is, what about SMILE? Already there are a couple of cases that were published also from India, where we saw that actually doing SMILE on sort of, not very good corneas might not be a good idea at all, because they also can develop keratectasia. So here again, similar setting, 13 donors, 26 fellow eye human corneas, same refraction, but again, right eye of the same donor received a PRK treatment, the left eye of the same donor received a SMILE treatment. And here are results, and the results are somewhat different. So when you look again, SMILE, now SMILE is not the line, the curve above, SMILE is the curve below, and PRK is the curve above, which means, there's a strain-stress relationship appears to better for PRK. Obviously, we also checked the statistics, and it turned out there was no statistical difference, but at least there's a tendency that PRK might be a better choice in terms of biomechanics. Now, since there's no statistical difference, this always was published, but honestly speaking, now, if you imagine, if we would have had instead of 26 eyes, perhaps 126 eyes, perhaps we could show a statistically different results. And now I come to something that's really new and hasn't been shown, I think only showed once, the Chinese mating. Because now, since we're all moving toward hyperopia treatment with SMILE, and I can assure at this moment it will work. We finished the multi-center study. I know the results are great, and we're in the process of submitting in for approval. And then thereafter, we will be able to show and publish the results. But what I already did, I think, okay, I realized that hyperopic SMILE is not an easy procedure. It's not as simple as normal SMILE procedure. Why? Well, because you have large, huge lenticles. These lenticles are sometimes 8.6 because we need the transition zone. The transition zone for hyperopia is very, very important. When you might think of one of my very, well, not first, but one of the earlier publications where Marcus Bloom and I, even in 2010, were attempted to do a hyperopic flex. And we realized we had a huge regression. So thereafter, I basically gathered all the old folks, from Zeiss, who used to develop ablation profiles for hyperopia treatment. And hyperopia treatment with mil 80, mil 90 is very successful. And asking, what is the keys to success? Why doesn't it work? And they say, well, the transition zone is too small. Okay, fair enough. So we created a new profiles, and it was published in 2016 and 2018. And I did flex. I did over 100 eyes with flex, and it worked very well. Now, flex was easy because you lift up the flap. The problem with the SMILE is that you have a very large, let's say you have a 6.5 optical zone, then add to those 6.5 optical zone 2 millimeters of transition zone, it will give you a lenticle diameter of 8.5. Now again, the hyperopic eyes usually have small corneas, so there's not much room for the cap. So you end up with having the transition zone, sorry, the corridor, the clearance zone, where you can get with your hook in order to be above or below the lenticle, which is sometimes like 0.1, 0.2 millimeters. So now we need to see, what are the advantages of such a more challenging and demanding surgery. Well, later on, once we publish the hyperopic data, you will see that at least, this is my interpretation, is that the refractive data are more stable, but they're not much different from femto-LASIK. And this is why I already decided to look at the biomechanics, because, well, perhaps the biomechanics are better. So we had 26 fellow eye human corneas, again, with 13 donors, the same setting. Instead of -10, we went to a very high correction, the highest sort of possible of +6 diopters, with a 7 millimeter zone, which gives you the largest bulk of tissue removed. And again, a flap of 110 microns and cap of 120. I remember when I submitted the paper, the review asked, why 120 and 110? I said, well, this is because what I do in real life. When I do a hyperopic LASIK, I tend to use 110 micron flap. And when I perform SMILE, my standard setting is 120 microns for the cap. And as I show you, the transition zone is 1.8 millimeter. What's important is when we do hyperopic SMILE, unlike in hyperopic LASIK, you've got to have some minimal thickness in the center because it's absolutely impossible to remove a donut. This is, our ablation profile would be otherwise a donut. So in order to get a lenticle, actually you need to have some thickness in the center. Now, in those thousands and thousands of eyes operated on, I only had one severe complication, and it was a very early case of hyperopic flex where I had a buttonhole, because initially we were thinking that 10 microns would be enough. but they were not. Okay, so this time we decided to use a 25 microns. As a matter of fact, Dr. Pradhan and Dr. Reinstein already published a paper on hyperopic smile from Kathmandu, and they even used 30 microns. But then again, if you have a thicker center, it also increased the amount of tissue at the periphery. So those are these things to be thought of, and then I'll show you the results. Here we are. The stress-strain relationship with a median of 14.8 megapascal versus 11.6 megapascal, and elastic modules, when you look, they're not much of a difference. So there's absolutely no statistically significant difference. In even, unlike, I show you with the PRK in myopia, I don't think that if I would increase the number of eyes tested, I would get different results. So basically, whether it's hyperopic smile, hyperopic LASIK, in terms of biomechanics, we get very similar results. Now I come to the conclusion of my talk, and we'll have hopefully 1 or 2 minutes to discussion. So for myopia, it is like we all know, smile is better in terms of biomechanics. It's roughly 30% stronger than femtosecond LASIK for the same correction. And as you increase the correction, the difference even becomes larger and larger. So it makes much sense to offer smile surgery, particularly to young patients. This is why I offer smile surgery, female, or those ladies who are in an age where they might probably get pregnant. But smile has no advantages over PRK in terms of biomechanics. Obviously it has other advantages, nice comfort, whatever, no pain. But in terms of biomechanics, so if you do have sort of queer cornea, you don't like it, it's quite okay to say, and this is what I do. Nowadays, instead of going for smile, and obviously no femto LASIK whatsoever, let's do PRK, okay? But the hypermetropia is different. So how do we explain that there is no difference between smile and femto LASIK, because we all sort of got used to it? Well, first, as I said, there's a much larger bulk of tissue removed due to the central 25 microns, as opposed to donut-shaped ablation when we use excimer laser. Now, again, the tissue we remove in hyperopic ablation is the tissue at the periphery. And remember that the mid-peripheral stroma is the strongest part. It's the anterior, but not anterior in the center, but anterior and mid-peripheral. Now, also, in order to to adjust to get to the lenticle the easiest way, I did not use a 2 millimeter incision. I used 4 to 5 millimeter incision, because otherwise one gets in real trouble to get the lenticle out. So it is a larger opening. And well, who knows, cap per se might be a barrier of the elastic behavior of the remaining corneal stroma, because theoretically, we enlarge the surface of the cornea because we steepen it up. But here we have a strain of the cap, which cannot be stretched forever. Now, if you think of your LASIK cases, you do a hyperopic LASIK, you really have a large gutter at the periphery. Why is it? This is because we enlarge the surface. Here, the cap could be like a strain not to move the cornea the way we want it to be. And perhaps, and it's something should be shown in the future, it might be even better to have a central corneal, or not corneal, central lenticular thickness of more than 25 microns, perhaps 35, just to create some space within the cornea in order for the cornea to adjust to the new shape. So those are the things I wanted to share with you, and I'd be more than happy to discuss it. So in conclusion, while the myopic smile is a way superior to femto LASIK in terms of corneal biomechanics, it did not show any difference for hyperopic corrections in our in vitro studies, but in vivo studies might change it. Once approved, hyperopic smile will have to be studied thoroughly in order to figure out the advantages and disadvantages of femto LASIK. I hope, perhaps less dry eye, because dry eye is quite an issue, particularly in hyperopic ablation. But, this is, how we're going to see what's going to happen then. All right. Thank you so much.
Thank you so much, Dr. Sekundo. It was a fantastic talk. And I just wanted to have a couple of questions from my side. Actually, I've been doing Smile and also Presbyon for the last 8 to 9 years. But a lot of my friends been, I think, doing Smile monovision for presbyopia. But I prefer to do Presbyon. But since we are not accessed with the hyperopic license in India, except for a couple of centers for trial, so you have got a large experience with the hyperopic smile. So have you done hyperopic smile in presbyopic? Those patients are hypermetropic with the monovision trial. What is your results?
I did indeed, because the majority of my patients were rather low hyperops. I think the part from Marburg, I did 96 eyes for the of 374 eyes we treated in this last study. I did 96, and I had a mean spherical equivalent of plus 2.2, and I would roughly say 1/3 I did basically monovision, and it works wonderfully.
Yeah.
But whether it's just because it's presbyopia, I mean, if you think back, before we had presbyon and all the other things, and we did monovision for hyperopia, it also worked very well because it induces spherical aberration and it gives you the depth of focus. But yes, it worked very well. As a matter of fact, the head nurse of my operating theater, she's got it. And I really envy her, because she can thread a 10-0 nylon and I can't see it. I have to look under the microscope, and she does it without glasses. And this lady, she's 58.
Thank you so much. Professor Tityal is here. I think he's the man who has written the textbook of Smile, who is doing a high smile surgeon. I want Professor Tityal.
Thank you, Kudlu. Wonderful lecture, Dr. Walter, and thank you for your inputs in our book also. And I just like to have one query solved from your side, both for a smile as well, a myopic as well for a hyperopic smile. What is your experience with patient with a slightly higher cylinder? Have you included cylindrical power also in hyperopic corrections?
Yes, the hyperopia was both sphere and cylinder. We do tend again to undercorrect slightly in very high cylinders. It works extremely well for sort of 2 diopters of SIL. Works very well, and I can assure it, because at the moment I already started to write up the paper, and obviously because there's so many authors, it will probably take some time, to get agreed on the paper, but then we will submit it. And the data are all right. They're not brilliant, they're not bad, they're all right, and extremely competitive to the femtosecond LASIK.
Good, that's very good.
Walter, really good to see you again.
Good to see you too. I wish I could see you in person, Rupal.
I know. It's been such a long time. I just wanted to say that even if the results are the same as we had seen even in the earlier ones, the flex results that we did, simply not having a flap is an advantage, because that itself is going to allow you to relax in terms of the post-op complications that are possible. So even if the results are the same as femto-LASIK, I think Smile still is the way to go. Also,
I'm sure people also will use it, but I think what my recommendation will be after the surgery, that hyperopic smile should not be given to a novel smile surgeon.
yes.
Hyperopia should be given to those who've done enough myopic smiles. Similar, as you remember, as you and I, when we started flex, pseudo smile, and so on, because it was, even to my surprise, it was more difficult just because it's huge lenticle. You get such a bulk of tissue out of it, and it's enormous. Yeah.
Professor Walter, what is the hyperopic range that we are looking at?
Well, in the study, we went up to +6.
+6. So I think refractive stability, number one, and maybe less incidence of dry eye could be two added advantages as
Well,
over
I must admit we did not look at the dry eye characteristics in this study, but the refractive stability, at least this is my opinion. You know, when I said it looks a little bit better than what we have with femtosecond LASIK. But I hope, as Dr. Shah just pointed out, I just hope that the problem with the dry eye will become perhaps less of an issue, because this is a real trouble with hyperopic ablation as you compare to myopia treatment. Yeah.
One more quick question, or last quick, and then we move to the next one.
Yeah. Yes, thank you. And I think Professor Sekundo, we really enjoyed your pioneering work and the talk. So now, I mean, my actually question is regarding generally on the place of smile in your clinic versus like now when you have access to surface ablation, femtosecond LASIK, and smile. So, like, basically, what are the patients you are currently choosing for surface ablation and femtosecond LASIK? Like, your predominant procedure, of course, is going to be smile. But what are the patients that you are choosing currently where you would like to do a surface ablation and a femtosecond LASIK procedure?
Well, again, surface ablation for me are those the corneas sort of I don't like. You know, corneas like don't feel very comfortable, and I use everything, even if I don't believe, do not trust entirely into Corvis. I also use Corvis in other things to feel comfortable. If I don't feel comfortable, I would still turn to PRK, just because that's what my results show. For normal ablations, particularly myopic ablations, I always use smile, roughly till the age of perhaps 45. And from there on, it becomes Presbeyond. And as a matter of fact, I showed it one of my meetings in 2016, 80% of my laser refractive surgery was smile, and the rest of the femto-LASIK. Now, it's only 60% smile, and the rest femto-LASIK, because once I entered the Presbeyond era, and particularly in our population is much older than your population. So I recently looked at the numbers. The mean patient age in my clinic is at the moment 42. So I mean, Presbeyond is a real issue. So the next step for me, and I already discussed it even with people from Zeiss, is moving, as it was mentioned, just recently moving towards the Presbeyond smile, because this is the age of our population. But also, again, we do know that the visual recovery in those age 40 plus with smile is slower than with femto-LASIK, whereas young patients really enjoy smile. Also, we developed our own nomograms, which we published for Presbeyond, because I do Presbeyond in a slightly different way than it was shown by Dr. Reinstein. Reinstein uses 6mm zone. I don't like small zones. I use for myopia 6.5mm zones. But once you use a larger zone, the nomograms do not work. You've got to work out on your own nomograms, and that's what we did. And again, what we also figured out for Presbeyond, you've got to have a separate nomogram for the dominant and non-dominant eye. And I'm sure Dr. Krishna will be able to support my statement. But this is what we do. Young patients smile, older, over 40, more toward femto-LASIK, and then once they reach the presbyopic age, femto-LASIK as a Presbeyond procedure, and PRK for corneas that are not good, but it's 3 to 5%, not more than that.
Yeah, that's great. Thank you very much.
Yeah, we have with us Professor Rohit Shetty, who has been doing a lot of research work on the different refractive procedure. I welcome Dr. Rohit. I think 1 or 2 comments from the Dr. Rohit. Unmute, Rohit.
Thank you, sir. Thank you, Professor Sekundo. Nice seeing you. One of the things which I want to say is the smile and LASIK depends on how the wound healing happens, has the same type of biomechanical stability when it reaches after 6 to 7 months. Lot of in vitro studies and in vivo studies are completely different. However, PRK still stand the test of time as being the strongest in all forms, whether you do in vitro and in vivo studies. And now at this point of time, we are doing some work on collagen orientation itself. And we feel that there is significant change in how the collagen is protected in smile, but that should not give us that armor saying that I would do smile on a patient who is suspicious. That is just to tell us that it will prevent you maybe from regression or help you remodeling of epithelium gets much better in smile. But I don't think it gives you that armor to do it on even a slightest of suspicion. And quickly, the second point I want to tell you is the genetic. We are sending this paper to the IOVS this month. The genetics of healing of smile and LASIK is completely different. That's why the type of ectasias you get in smile is not the same type as you get in LASIK. In smile, sometimes you get ectasias in a near normal looking corneas, because the complete gene pathway of healing is different. It's a very, very interesting concept. I don't want to take anybody's time here, but I just want to say that healing is driven by genes, and genes are different in different processes. That's why your risk factor of developing ectasia in smile is completely different from developing an ectasia in a LASIK patient.